Okay, team, let's hit the ground running. Time for the blitz. Narrow Complex Tachycardia. Let's go.
Rule 1. See a regular rhythm? You're thinking SVT. Hit him with vagal maneuvers. No change? Adenosine, 6 milligrams, slammed IV. If it converts, you've just diagnosed and treated it. Next.
See those classic sawtooth waves? That's atrial flutter. Don't even hesitate.
Now, if it's just chaotic, irregularly irregular, no P waves in sight, you're looking at atrial fibrillation. The big one, the stroke maker. Stable, we're controlling the rate. Beta blockers are your friend.
But, and this is the most important rule, if they are unstable, hypotensive, altered, chest pain, the answer is always, always immediate synchronized cardioversion. And for any AFib patient, do not forget to calculate that CH2DS2 VASC score to figure out their stroke risk. It boils down to this: rate, regularity, and protecting that brain.
Okay, let's slow down. Before we dive any deeper, we must address the mandatory disclaimer.
This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
All right, now for the deep dive. Let's really deconstruct this. Sarah, you're with me? So, a patient comes in, heart's pounding away at 160, EKG shows a narrow QRS. What's the absolute first question we have to ask?
We always start with regularity. Why is that our golden rule?
Because, Dr. Collins, it splits our differential right down the middle. If it's regular, we're almost certainly dealing with an SVT, AVNRT or AVRT. And the 2023 ESC Guidelines give us a crystal clear path. First, try a modified Valsalva. If that doesn't break it, it's time for adenosine, 6 milligrams followed by 12 if needed, and you have to push it fast. Large bore IV, rapid saline flush right behind it.
It is genuinely terrifying for the patient, and for us, honestly, because for a second, their heart just stops. A flatline. It's a hard reboot, designed to interrupt that re-entry circuit and let the normal pacemaker take over again.
Exactly. A cardiac reboot. Perfect analogy. So what if it's not regular at all? What if what you see is just chaos? An irregularly irregular rhythm? No discernible P waves, just these fine fibrillatory waves.
That's our diagnosis of atrial fibrillation. The atria are just quivering chaotically. And with AFib, the rate isn't even our biggest fear. It's stroke. That's the real danger. Blood stagnates in the left atrial appendage, forms clots, and can travel straight to the brain. That's why for the boards and in practice, we absolutely must use the CHADS2 DS2 VASC score to decide on anticoagulation.
Outstanding. And for everyone listening, remember the new 2024 ESC Guidelines hammer home the ABC pathway for AFib management. A, anticoagulate to avoid stroke. B, better symptom control with rate or rhythm strategies. And C, cardiovascular risk and comorbidity management.
So that covers our two big categories, but there's a scenario that overrides everything. The ultimate red flag. When do we forget the algorithms, stop reaching for drugs, and grab the paddles?
Instability. That's the one. If the patient has any sign of it, hypotension, altered mental status, signs of shock, ischemic chest pain, or acute heart failure, we're done with medications. The answer is electricity. Immediate synchronized cardioversion. It's non-negotiable.
Absolutely correct. Okay, let's switch from algorithms to reality for a second. I want to ask all of you watching, have you ever been the one to push that adenosine and watch the monitor go flat? That long, heart-stopping pause of asystole, it feels like forever, doesn't it? Share your adenosine stories in the comments. We'd love to hear them.
All right, Sarah. Time to lock these rules in so they're second nature. Let's do the Mary chant. Ready?
Regular is SVT, adenosine.
Dr. Collins and Sarah. Irregular is AFib, anticoagulate.
Sawtooth is Flutter ablate.
Stable is the drug.
Unstable is the plug.
Rules locked. Dr. Collins, excellent. We've mastered the narrow complex lane. But what happens when that QRS gets wide? That's when things get really interesting. Join us for our next session where we dive into wide complex tachycardias. Make sure you subscribe to Clinical Crash Course so you don't miss it.